So I heard this is a talkative group. Is that true? So I'd like to try to engage you in maybe some discussion as we go. I would generally ask that if there is a question that it's not of a deeply personal nature, we could maybe save that for maybe a private discussion later. But if it relates to the content at hand, if you have the question, I'm sure 10 other people do as well. So we could take it as we go. And why did I start with these topics? So fatigue, I think is incredibly common. And if we're going to be honest about this, if we don't have the energy to do the things that we want to do, that's really distressing sometimes, right? If we can't function and integrate into our roles, sometimes it could lead to a sense of helplessness. And I want to give you some strategies on how we could break that and not only break the fatigue, but it turns out many of the things that can improve fatigue seem to improve survival for many cancer types. So we'll talk about that connection. So I'm going to start with this. So I know this is a silly question, but I'm going to ask any loved ones or caregivers here, spouses. Okay, this is really for you. Because somebody who has not experienced fatigue from chemo, radiation, etc., really have a hard time understanding what it is. Any idea? How would you define it? Or it could be anyone, but it's really intended for you.
Lack of energy.
So lack of energy. But if I'm up, let's say to a wedding, and I stay up till 2 o'clock in the morning, and I still wake up at 6 to go to work, I'm gonna be tired. But I could tell you that fatigue is not really the same as the fatigue for somebody that has been undergoing surgery, chemo, radiation. And it's important for our loved ones to know that. Because if I took a nap after being up all night, I'll get refreshed, right? Or if you get a good night's sleep, you generally feel refreshed. People who are going through all this treatment will tell you, I'll still sleep 7, 8, 9 hours, and I still feel like a truck ran over me. So the idea that, number one, it's generally not relieved by rest is one part of the definition. And number two, it interferes. It interferes with our, again, as we're talking about, with our ability to do our daily activities. And really the third part is it's not proportional. So I don't have to tell you all this, but people will say, all I did was a load of laundry and a couple of errands, and it wiped me out. Whereas, before I could have done all these things. So it's not proportional to how much I did. So these are the basic elements of the definition. Okay, it's very common. Sometimes it can be quite distressing. Depending on which study you look at, for some people it lingers for months or longer. And this is really why I like to give these talks, because right, we can help that 1/3 of people potentially that continue to struggle if we can, proactively engage them. But there is a lot of variability. And one of the things that we've learned, and we've published on this, is we used to assume that it was just how much chemo you got. You get 3 rounds of chemo, you get less fatigue. You get 6 rounds, you get more fatigue. Or if you get this type of chemo gives more fatigue and this type gives you less. And that doesn't clearly seem to correlate. And any ideas on what are actually the most important risks for having more significant fatigue that lasts longer? What do you all think? Like, why do some people have fatigue that just is harder to deal with and lasts long? Okay, so pain is definitely a factor, but it's not probably the primary driver for most people. Yes.
I think the immune system.
The immune system definitely has something to do with it, but the question is, what in our life affects our immune system? Yes. Lifestyle. And you want to pick what?
Nutrition, how we exercise, the amount of sun we get, the amount of mind-body balance.
So we're gonna get into all of those things. Yeah, we're gonna get into all those things. Support system, I think, is a critical part of it.
Quality of sleep.
And I'm glad you brought that up because quality, you said quality of sleep. So again, we just published on this a couple of years ago. So this was a study we did with UCLA. Trying to figure out again why some people have more fatigue than others. And again, chemo did not differentiate this as we had anticipated. Now, again, there were some limitations because a lot of women in this study were women that had radiation surgery and hormonal treatment for breast cancer, and many of them didn't need chemo. So maybe that was a reason why. But these three things we consistently found to be most predictive. Depression, distress, which means anxiety and worries and other concerns. And as you mentioned, sleep. These three things really seem to be most predictive. And this we published a couple years ago, just last week, down the street, our colleagues at City of Hope. This really caught my eye. They just published, anybody get treated at City of Hope here? I imagine a bunch of you. So William Dale and his group just came out with this where they showed, at least for older individuals going through chemo, if you had depression before, that increased your side effects, neuropathy, fatigue, even somebody said immune system issues like, counts being decreased and whatnot, things that people assumed had nothing to do with each other, right? This is your mind and this is your body. What is the side effects from chemo have to do with your state of mind? He just published this paper that depression magnifies side effects during chemotherapy. Okay, one of the points I want to make, and this is why you have to work with one of your docs. Hopefully you have someone in your team that can help you with this. This is just a hypothetical example of two different people. There's these scales. They ask you, what's your fatigue level from 0 to 10? 10 being the worst imaginable, 0 being no fatigue at all. And I could come up with a scenario where two different people, both say it's 8 out of 10. So pretty significant. But imaginary patient number one, could have a lot of that fatigue being driven by depression. Maybe their pain medicines is a part of it, and pain. And then the other person, doesn't have any depression, but they've lost so much muscle. Cachexia is the term for muscle loss, from, let's say, treatment and deconditioning, or you're anemic, or your blood counts are low, and those are really driving the fatigue. And the reason I bring this up is the idea that there's one solution for everyone is simplistic. So please take the suggestions I give you with a grain of salt, because we really have to work with your own docs on trying to understand what are the factors behind your fatigue if you're having it, and then how do we unravel that based on your profile. Okay, so somebody should be putting some thought into this, because in my mind, this is a busy slide by intention. There are many things that cause fatigue in the cancer setting. And just think about this, right? And I'm not going to go through all this because we're not going to have time in the time that we have together to go through every single one of these things. But you'll notice one thing is kind of bolded in yellow, right? And it's bolded because many scientists in this space are arguing that it's one of the major drivers of cancer fatigue. Anybody know what these cytokines are? That's bolded. Anybody heard that term? You've heard it. Something to do with white blood cells, yeah. Even though you may not know the medical term on what it is, I could promise you've all experienced these cytokines. Everyone here has had the flu at some point, right? Or a bad case of COVID, maybe. How do you feel for those 3 or 4 days when you had the flu? Terrible, crummy,
Depleted.
depleted. Did anybody want to go run around and, go for a jog? Did anybody want to study for a midterm? We're just sitting in bed, right? So we feel exhausted, right? We feel cognitively foggy. And it turns out it's not the flu virus that makes you feel, it's not even COVID that makes you feel so crummy. And as somebody in the back said, it's your immune system response to the flu. So you get the influenza, right, virus, and one part of your immune system intentionally produces these cytokines, we believe, to create what they call sickness behavior, to cause fatigue, exhaustion, some sadness, right? If you think about when you have the flu, most of us kind of feel a little down for those few days, right? So why would your body want to, and it's doing this while a different part of the immune system is trying to create antibodies to deal with the virus. But why would this arm of its immune system produce these cytokines?
It's a protection
From what?
from tell you to stop and rest.
Exactly. So, right, because if you felt great when you had COVID,
You run.
you're going to keep hunting and gathering nuts and berries. It's only because you're depleted, exhausted, crummy, and all the things you all said that you stay in bed. Yes.
I'm just thinking too, but it also serves a social purpose, people that are very sick and contagious. Maybe they want to.
Quite possibly. I didn't think about that, but quite possibly. So you're not going to be in the town square, right, in the middle of this. But for all these reasons, right? So again, it's not the flu virus, it's your immune system response to the flu virus. Does that part make sense so far? Okay. Because then we're going to make the link. And by the way, you've probably heard, I don't want to get into this now, but initially when many people were succumbing to COVID, you probably heard the term, there was a cytokine storm. I don't know if you remember hearing that. That means there were massive amounts of these proteins being released by the body that just overwhelmed us, but that's another story. Okay.
So cytokines are proteins?
Well, they're basically a word for inflammation.
Oh.
Your body gets this virus, it intentionally produces an inflammatory response to give you the message to stay home. Because you need to rest while we deal with this virus.
Are those also referred to as spike proteins?
No, those are different.
Okay.
Yeah. Those are different. Okay. So let's link it back to the oncology world. And this is the working theory that, again, doesn't explain everything, but I think it tells a story. So the theory is that your immune system recognizes some cancer cells, and then it also sees like chemo, right? Let's say pummeling through the veins. And remember, chemo is like a foreign substance in a way, if you want to think about it that way. And so your body is doing what it was built to do. It sees something foreign, it produces those same cytokines, right? And you synergize that with the distress and anxiety that I know goes hand in hand with this whole process, because that also produces cytokines. And it's those cytokines we believe, at least in part, is driving the fatigue. Just like when you have the flu. So the difference is the flu lasted 3 or 4 days. You go through surgery, 4 to 6 rounds of chemo, radiation, right? You get where I'm going with this. It's perpetuating itself for a while. Yes. I'm sorry. So yeah, so in the study I was mentioning, we measure them. They're research, relegated to the research realm. But if you have ever heard of something called like C-reactive protein or CRP, it's one measure of inflammation. It's not the only measure, so it doesn't tell the whole story, but it's the most kind of commonly used available measure for, that some doctors choose to check in your blood. CRP.
So are you also saying that if you have depression, that's not 100% mental disease? It could be some of part of it could be physical.
You know,
related.
the more, it's a tricky question, because the more, you know, thinking about these things, and not just me, it's many others, there is no separation anymore. I mean, there's a biological part to, sure, our experiences may be driving some of the biology changes, our thoughts and our beliefs particularly. But there is a biological part that goes hand in hand.
So what is the C with the CRP was the C? C is.
Oh, the CNC reactive protein, I don't even know. I don't even know what that stands for, if anything. Yeah, but it's a marker of some of the inflammatory pathways. Okay. So again, I've been using the word cytokines. And by the way, again, the flu that causes the inflammation. So we get the flu, inflammation goes up. And then as we get better, right, inflammation goes down again. Now, when inflammation lingers around chronically, you've all heard the term chronic inflammation driving many of our health issues. This is what we're talking about. It's these cytokines that, whether it's diabetes, heart disease, you know, certain cancers, all of these chronic illnesses have chronic inflammation or chronic cytokines driving them apart. So it would behoove us to figure out how to manage this. So in terms of how do we manage this? So I want to start this next part. And again, I wish I could talk about this for hours, but I just want to leave you with a couple of clues. So number one, you've all heard the idea of being apple-shaped or pear-shaped. Which one is felt to be more harmful?
Apple.
Why?
Yeah.
Right, so I always assumed, even, you know, many years ago, that it's the fat, like you said, in the abdomen, it's pushing on the liver, it's pushing on the pancreas, and somehow that makes it unhealthy. But that's not really why. It's not the location. Any other guesses?
What it is.
Exactly. So we now know that fat doesn't just hang around taking up space. The visceral fat, the bad fat that we're talking about that's deeply around the organs, it's producing something. It's not just, whereas subcutaneous fat might be more inactive, it's just hanging around. Visceral fat is producing these same types of inflammatory cytokines. So why am I talking about that now? One basic reason is, and I'm giving you the short version, that when we walk or cycle or swim or dance or do a biceps curl and move our muscle, these things are all reducing these cytokines. So there's a reduction. So I know that exercise alone may not be the best way to lose weight, if that's what you're concerned about, which I don't think it should be. It can reduce visceral fat. So I think we have to, in some way, stop looking at the scale, because it's not telling us about our biology. So exercise, number one, definitely reduces visceral fat. And I don't want to get into this right now. Okay, this is a story. I'll walk you through this, and because I know it's foreign looking right now. And I just tell this to make an impression upon you, because this is really eye-opening, and I think it's easy to understand. So somewhere in Scandinavia, I think it was Denmark or whatever, they did a study with healthy young college students. And they selected these young adults that were active, which they basically identified as walking 10,000 steps a day or more, okay? And they want to accurately measure their visceral fat, so they put them in an MRI machine. And when this is like a cross section of the abdomen, the feet of this person are pointing towards you, the head is towards the back. So the before picture is a cross section of one person, and that you see that white here, that the red arrows are pointing to, that's the visceral fat, kind of around the liver and deeper in the organs. Then they had these otherwise totally healthy young adult college students go 2 weeks, 14 days of telling them to be a couch potato, which means 1,500 steps a day or less. And then everyone went back in the MRI machine again. And you could see the numbers before you. On average, there was a 7% increase in visceral fat in just 2 weeks. Lean muscle mass decreased, their fitness level, that's what VO2 max refers to, your cardiorespiratory fitness, decreased. And you could see that one individual that they did it before and after. You see the white? Now, this was just in 2 weeks. What happens, as we were told in the 80s and even some of the 90s, when a well-intentioned physician tells you, you're going through chemo, just stay in bed and rest, which is what we did. By the way, that's what we did with, people had heart attacks in the 50s and 60s. They were given 6 weeks of bed rest. Now we know we're killing them, right? Now you have a heart transplant. They have you walking the next day, right? Or you have cardiac rehab program. Oh, okay. So you know what I'm talking about, right? Right? Because we know that's part of the treatment, right? You have a heart attack, they're going to get you to cardiac rehab. Yes.
How do you know, a non-researcher, the difference between the serial fat and cutaneous fat?
That's a great question. So visceral fat versus, first of all, it's not easy. So there are certain clues. Some argue for monitoring not your weight, but your waist circumference as a crude measure. Because it does correlate, right? It's hard to know how much of it is subcutaneous versus visceral, but it is a marker for how much visceral fat. So waist circumference is one way. You may have seen in gyms, we bought this for our team at Cedars. We now have a fairly high level in-body device where some gyms have them, some clinics have them, where again, it's not a perfect measure, but it gives a basic breakdown of how much muscle and visceral fat. And then there's something called DEXA scans. And again, you can get them privately and they become less expensive and they give a fairly accurate measure of your fat and bone mass and muscle mass. But again, for the masses, maybe just keeping an eye on your waist circumference might be one approach. Okay. Now, for the longest time, for really hundreds of years, we always assume muscle is important, but what is it important for? Why do we all need muscle? To do anything, right? We couldn't like lift a rock or push a chair or move our bodies if we didn't have muscle. And that was really the limit of our credit towards this organ. But again, things change and it's really been incredible what we've learned. So again, we're learning that when you do a squat, when you do a curl, when you swim, when you walk, when you run, and you contract your muscle fibers, it turns out, guess what? Your muscle's also producing something. Again, we didn't know about this until about a decade or so ago. Your muscles produce stuff. What is it producing? And this is where I'm not going to get into the nuances, but they produce these myokines that, guess what? They reduce the cytokines. So think about this from an ancestral perspective. Let's go back 100,000 years ago. Our ancestor had influenza. They felt horrible. They stayed in the cave, right? Because they felt exhausted for all the reasons we talked about. Now, after 3 or 4 days, when a different part of their immune system is dealing with the virus and they start feeling better, then what would they do? Go back to hunting and gathering, right? Because they wouldn't have survived, which means they would have been contracting their muscles, which means they would have produced those myokines, which means that reduces those cytokines. So there was this really elegant system of we get an infection, inflammation goes up appropriately because we would die, right, if we didn't have it. Or if we got a cut or a wound back then, there were no antibiotics. The only reason anyone survived was because there was a lot of inflammation, right? That's where we get like the pus balls and all the inflammatory cells going to that leg to try to heal. But we would have all died otherwise. So inflammation goes up. But then they go eventually have to get back to hunting and gathering. Muscles move, inflammation went back down.
So they had it better than us.
Exactly. So basically, in the last few generations, we've eliminated what I argue is like our natural kind of healing modality for managing inflammation. Right? Because I may have a flu and I stay home for a couple of days, but then when I go back to work, right, I'm sitting behind the computer all day. So inflammation goes up, but it never fully goes down to really, really low levels because of our lifestyle, at least in part. Okay, the third reason, I'm not the psychologist. I'm sure there's many psychologists here. What is self-efficacy? This is another reason why exercise reduces, maybe not inflammation, but reduces fatigue.
Self-awareness of your time efficiency.
Self-awareness is part of it. Anybody else?
Confidence?
Confidence is, I think, more on track. Exactly. It's this idea that if we have a goal, we can get it done. That we, right? That it's the opposite in my mind of helplessness. So we have a 3-month exercise program at Cedars. It's individually tailored. And we know that self-efficacy improves. Why? And I'll walk you through this in a second. You know, you come in being able to do 2 squats, and you leave being able to do 20. Just an example. And it may sound mundane. Well, what do squats have to do with anything? But I could tell you, when you feel like you've lost your physical power and your ability to do things, and you gain that trust in your body again, and you can do 20 squats and 15 push-ups and curl 10 pounds, I assure you it impacts your self-efficacy, so your self-confidence in other areas in your life as well. And again, so this has been written about where there's this idea that, yes, the bottom part of this slide is showing all the biology I was talking about, those inflammatory compounds. They don't have to worry about what they are, IL-6, TNF-alpha, etc., and how exercise reduces the inflammation. But if you look at the top, our self-efficacy and self-confidence improves with exercise. And that all helps with managing fatigue. So this is what self-efficacy is. This idea that I'm resilient, I can get through this, I can figure this out. And exercise is just one way in which we can improve our self-efficacy. I'm going to skip through this for time. Okay. And then exercise helps fatigue because we improve our fitness. And this is a simplistic answer, but if you don't want to remember anything else I talked about, maybe sometimes the simple stuff sticks with us the most. So we're tired, we have fatigue from the surgery, chemo, radiation, right? And the normal response to fatigue is to rest, right? And be inactive because we're tired. But this is where things get complicated very quickly, because being inactive for a while, and it doesn't take that long as you saw, then you get deconditioned. And that deconditioning, it turns out, makes the fatigue worse. And then you're active less, and then you're more deconditioned. This happens much more quickly than I think most of us realize. And so one of the goals with an exercise program is you're tired, but we find the right level of exercise for where you are, which improves your endurance a little bit, which actually gives you a little bit more energy, and you're trying to break it to this kind of pattern. Okay, so before I leave this section though, look at the slide again. I was focusing previously on the cytokines causing fatigue. Now, you may have noticed that there are some people that are arguing that these cytokines may also lead to a higher rate of recurrence or progression, at least for some cancer types. it's been associated with, let's say, like breast cancer, ovarian cancer, colon cancer, many of the solid tumors. It's been associated with that. So then the question is, again, if exercise can reduce the cytokines, can it reduce the rate of recurrence or progression? Right? That's a logical question, right? And again, I intentionally am showing you this medical slide without trying to overwhelm you, but just to make the point. We're now learning that when you do a squat and dance and run and jump, and you contract those muscles, your muscles, in addition to those myokines that I was talking about, are producing these other compounds that really seem to be fighting cancers. Particularly, as I mentioned, this has been most studied with breast and colon cancer. That's what the slide is showing. And let's just go over the data for breast. And I'm going to read, I try not to read slides. I'm going to read this one because I don't think people hear this enough. One study found a 28% reduction in breast cancer specific mortality if you're active versus a couch potato. And all-cause mortality cut almost in half if you're active versus a couch potato. Another study, a 41% reduction in breast cancer specific mortality. And by the way, this is activity after the diagnosis, not what we did before. Okay. So I'll frame this a couple ways. Yes.
There is differentiation between what in studies reflecting activity during chemo treatment or.
No, this is mostly in the months and years after.
Oh,
Now, activity during chemo, they've done studies to show that at least number one, it reduces fatigue. There are studies occurring where, for example, in Australia, they're literally putting like stationary bikes in the chemo infusion suite. So you're on the bike 30 minutes before, after chemo. And the theory, and again, this needs to be sorted out still. The theory being that if you're pumping, right, your blood, you're getting the chemo delivered more efficiently into, the tumor bed so that it gives a bigger punch. Before, I think this some more work needs to be done, but this is for the month and years after that we're talking about. That's pretty well substantiated. So there was another point I wanted to make. So I'm not trying to say that it makes our risk down to zero. I'm not trying to give false hope, but 40–50%, I don't think is a laughable number, right? So it's still meaningful, even though nothing's bulletproof in our lives. So this was handout produced by the American College of Sports Medicine, where they got all these experts together, and they voted on what they felt had strong. You can get this online, right? This is printable. Strong evidence, right, on how much aerobic and resistance exercise you need for fatigue, for functioning well, for anxiety, for depression, for lymphedema, etc. But the bottom line is, I'm going to tell you the bottom line on the next slide. Oh, a couple more slides. Okay. Before I get into that, so there's all this evidence that exercise helps depression, anxiety, fatigue, maybe recurrence for many cancer types, right? Sounds pretty good. Why am I even talking about this stuff? So when you look at the data, on average, women decrease their activity by 2 hours a week after diagnosis of breast cancer. If you look at cardiac fitness for women treated with chemotherapy, for example, it's as if women have aged 20 to 30 years. I bring that up because this is treatable, right? This is preventable. And then most concerning to me, and actually, before I share this slide, it's the next point. Hope you didn't read it. How many of you, I mean, you can answer either way. I mean, how many of you were counseled by your nurse, your doc, someone, not a lecture, just even counseled, like, it's important to get, and we'll talk about how much, this much exercise during or after chemo, after what you've gone through. I'm just curious. Zero. Okay. So according to this study, it was 21%. that recall, and I've seen studies anywhere from 3% to 30 or 40%. It should be 100%, okay? Now. Here's the bottom line. Oh, and maybe I'm not gonna finish all my slides. I don't really care. So when I had much more hair and I was starting to talk about this like 12 years ago, I'll never forget. I was giving a talk to our oncologists, and there was this senior oncologist who kind of heard all this stuff. And after the talk, he pulled me aside. He said, you know, this all sounds good. I appreciate your enthusiasm for this, but let's not waste your time. Let's not waste my time or our patients' time. It's like, because no one's gonna change what they do anyway. That's what, and I had nothing to say to him, because I was right. I was fresh and green, and I didn't know what to say. And then it was kind of interesting. Then literally like a couple of months or a few weeks later, I went to a conference, and it was a kind of a history of medicine conference. And during the conference, they were talking about how in the late 1700s, early 1800s, doctors prescribed smoke enemas. You know what a smoke enema is?
Sounds awful.
Sounds pretty bad, right? Where they're literally blowing smoke, right? And they would use it to treat infections, cancers, GI disease, all kinds of things.
And when is this?
Early 1800s, 1700s, not that long ago. Now, why would any patient, right, accept the smoke enema? Maybe not in desperation. What else? Their doctor told them to. Right? Somebody told them to. So I personally think it's easier to go on a stationary bike or swim than get a smoke enema, but you can decide.
Another thing is, I think partially it's true that it's very difficult to change one's lifestyle or exercise, habit or eating habit, for that reason. But like, for example, I used to commit to exercise programs. So my health was okay. I mean, other than cancer, but after the pandemic, 4 years without exercise, I have a lot of red, all the analysis all become red. But I did realize when I was committed to exercise, before I go to exercise, I struggle a lot. I don't want to get out. I don't want to go. But then I went anyway because I'm committed. And afterwards, I feel better physically and emotionally.
Sure.
But I signed up my husband for exercise. He didn't want to do it. He didn't even go. And after his triple bypass, it changed.
Yeah. So sometimes it takes major events
Yeah.
To be the catalyst.
I'm the couch potato. I have to admit.
Well, we're gonna talk about
Can you
the idea
explain
that doesn't take much.
Can you explain the last slide? What is that, 3 years and you age?
Oh, so when they've done some studies where you look at cardiovascular fitness for breast cancer survivors, so a 45-year-old might have the fitness of a 65-year-old.
Why? Because
The effects of
Is
the
that-
chemo, the radiation, et cetera,
oh,
and presumably also deconditioning, so a little bit of all of it.
or is it because they are already that bad, so they have breast cancer?
That's a good point. There is some concern for shared risk factors. But again, this is modifiable, so I don't think we're kind of doomed to have that. We know you can intervene.
And that's just stage 1 studies.
Early stage, so there could have been 2. Yeah. No, I don't think that's necessarily the case, but again, but not moving definitely compounds at all. Yeah. Okay, so how much do we, and by the way, it's not an all or nothing kind of situation. So, but even the best of goals seem to be 150 minutes. So sometimes people get in their head that they have to do, just hours and hours of exercise that's really intense. It's 150 minutes if it's moderate per week, or 75 minutes if it's vigorous per week. That's it. Now, how do you know what's moderate, what's vigorous? But what if you don't have, okay, so yeah, you're on, right, so go ahead.
You can, if you're eating, then it's vigorous, and if you can breathe and talk, then it's moderate.
Exactly. Y'all hear that? So if you can sing a song, it's too easy. You gotta take it up. If you cannot talk, even in a short sentence, then that means you're in the vigorous zone. Moderate for most of us means I could talk in a short sentence, but not sing. And that's a pretty, again, it's not perfect, but without having to put you through a stress test and coming up with all the formulas, that's a pretty good estimate. Okay, now when we're in the middle of chemo, or really in a hard time, there's what they call energy conservation techniques, delegating tasks, having things for our friends to do, pacing ourselves. Everyone has their ideal time of the day, right? Whether it's morning or afternoon, and trying to, plan around that. And overstimulation seems to also, when you're in the middle of chemo, you've all experienced this, seems to make things worse. So I kind of view this as the common sense stuff, but I hate to overlook that. There's been some studies on ginseng for fatigue from chemotherapy. I would say it has a modest effect. It's not like a blockbuster, but for some people that modest improvement can make a difference. Now, there are potential drug interactions, right, with any supplement, including ginseng. So you do have to talk to your docs about whether this is safe for you or not. But the typical dose, it's usually 1,000 milligrams twice a day. And most people need to take it for 6 to 8 weeks before it fully works. But it's another option. You may want to talk to your doc. And then again, only in certain situations do I come to the medicines. Usually I try other things, but there are stimulant medicines like Ritalin and modafinil. Certain antidepressants are energizing for some people, that you, again, on a case-by-case basis. If someone has metastatic cancer and they're really wiped out, and they need a little boost for a vacation they're going on, steroids can help. Again, all this needs to be kind of sorted out with a doc that does this kind of work. But I just wanted to leave it in the background. Okay, and this just came out. Again, there's so much, even though it's not the same, but there's so much overlap between the symptoms of depression and fatigue. I just wanted to highlight the study that came out that showed again that exercise has very meaningful antidepressant effects. Anybody want to take a guess? Actually, in the study was really interesting. They looked at all different types of exercise and how much of an antidepressant effect it seemed to have. And again, it's not a perfect study because there's some of them, there are more studies than others to kind of weigh the statistics. But anybody want to take a guess, at least in this analysis, what type of exercise or activity seemed to have the strongest antidepressant effects? Walking was there, but it wasn't the strongest. What? Sex? No. I wasn't on the list though. What's that? Zumba? You're on, yeah, exactly. It was dancing. It was dancing. I was really surprised. And again, this is a large study with 14,000 individuals, because they grouped together a bunch of smaller ones. And then they compared it to psychotherapy, antidepressants, and controls. And I don't want to skip through that for time, but this is the part I want to show you. So statistically, if you're on that red line, that means it's not as convincing if there's a real effect or not. So the further you go to the left, the more clear of a signal there was. And what you'll see it on the top was dancing.
Pickleball isn't in there.
No.
I think that's been a more recent phenomenon. I mean, at the end of the day, they all work, right? So dancing, walking, jogging. But if you compare dancing or walking or jogging, and I'm not telling anyone here to like not take an antidepressant, but because they work for some people, but it seems to work better. Right?
It's usually you have a partner, so it's more sociable, you know.
For dancing.
Yeah.
So I think that's part of it. I think the social part is a part of it. But there's also something about they seem to, neuroplasticity wise, this the idea that you're in rhythm.
Plus music. Music could be a
And
therapeutic.
that there might be something else to it.
That's just sound wrong.
That's an antidepressant, like Zoloft or Lexapro.
So if you exercise and take an antidepressant, you're. further
Again,
along.
you have to individualize this because it doesn't work for everyone, and antidepressants work great for some people, but I think if anything, the combination is probably better. Yes.
Just wanted to offer this, because of what was pointed out about dance, there's actually something called intuitive movement. And so you can do that alone or in groups, so you're still in a social setting, but one of the benefits of that is that as you're moving and you're dancing, you're interpreting the vibrational frequencies in your own way. And if you do it long enough, you release emotional trauma, which then brings more body, mind, and balance to your life. So intuitive movement is a really very helpful holistic modality, and you can find them all over LA. You just have to look for them. And it provides a lot of facilitating. Just thought I'd put that out there in case anyone thinks it's only partner.
Yeah, I mean, there's many different forms of dance, and I'll have another point, but I'll answer some questions first.
swimming fall under that classification?
Swimming.
Swimming?
Yes.
Yeah, it's not on, at least on this one analysis, but again, it would probably be the same as walking or jogging. Most likely. But again, to the point that's been made. I have patients who, when they're in the water, they're in the happiest place in their life, whereas other people hate the water. So I think the idea that there's one solution for everyone is obviously too simplistic, but the idea is exercise at the end of the day.
Also dancing, you have to be more mindful and you have to memorize the steps and all that. So all that differentiate with the rest.
Maybe. There was actually another study came from Scandinavia. I don't have a graph for it, where they wanted to look at survival for people with getting the different types of exercise. And this was Scandinavia. So on their list was soccer, they called it football, I think, badminton, jogging, going to the gym, a few others. Which do you think showed the highest impact on survival? I was surprised. I assumed, I'll just tell you what I thought. I just thought it would be jogging or going to the gym. It was soccer and badminton.
It's a group.
Because it's the social piece. It's the same idea. Their theory was it's exercise, but it's the social piece that seems to be important. Okay. So in this study that I just presented, they suggested that walking, jogging, yoga, strength training, dancing were most effective. If one is taking an antidepressant, exercise may make it even more beneficial. And again, we have to figure out what's best. They had some sub-studies where in their analysis, they found that yoga or qigong may actually be better for men, and strength training might be better for young women. Yoga was somewhat better for older adults. Again, I take that with a grain of salt. Okay, I'm going to skip through this. Okay. Questions? Any questions about any of that?
So does this mean that athletes will have better health both emotional and physical
Okay.
health.
So since you brought that up, okay, and I'm gonna give this analogy, which I think is an important one. We already said that if you're a couch potato, your inflammatory markers are higher, generally speaking, right? Combined with visceral fat. Now, when you look at people training for the marathon, like an ultra marathon, it turns out they get more colds, they get more flus. If you give someone training for an ultra marathon a vaccine, they have less of an antibody response to the vaccine than people getting moderate amounts of exercise. So there's this concern that when you really overdo it, you're kind of stressing your immune system out to some degree. Now that said, when you look at survival curves, I'm just going to draw it. It's this common pattern where the higher you are, the higher mortality rate. So couch potatoes have the highest mortality rate. And then you get off the couch and mortality starts dropping pretty quickly. And it drops the more you get. But at some point, there's a little bit of an uptick, just a little bit. Now, in fairness, marathon runners still have a far lower, mortality rate than couch potatoes. But I think the point that I'm trying to make is you don't need to overdo it. At some point, you get diminishing returns. So again, 150 minutes, you could do more if you want. Are you going to get that much more out of it? It gets diminished. But going from 0 minutes a week to 40 minutes a week, there's a huge difference in, again, inflammation and, mortality, et cetera. I hope that makes sense.
It said that even he has patients, marathon runners still get bypass.
Well, I think it's what I'm alluding to. Once you get past a certain point, it may be stressful on the immune system and cardiovascular system. So again, I'm just advocating for 150 minutes. Or if it's vigorous, like running, it really is like 75 minutes. Some will argue, they might get a little bit more benefit from going from 150 to 300 and going for moderate and for vigorous from 75 to 150, but it's probably, again, diminished in terms of how much more benefit you're getting. What else?
So is it more important to bring your heart rate up? You must have like more aerobic yoga or Pilates really doesn't cut it. Is that?
Well, okay, we could talk about this. So I personally believe that strength training is undervalued, and there's a lot more research that's occurring recently, but I didn't talk about this. Ideally, and it was in that other slide, twice a week you should have strength training, ideally. The problem with talking about it in a group setting is that's where you can get hurt, right? If you don't know what you're doing, right? If you don't know how to do a squat properly, you may hurt yourself, or if you don't know how to do a deadlift or shoulder press. So whether it's a trainer or a physical therapist or somebody that could oversee the strength training, that takes a little bit. Generally speaking, walking, cycling on a stationary bike, elliptical, it's very unlikely to hurt yourself, generically speaking. But ideally, you would do both strength training, which yoga and Pilates can include, and aerobic. Anything else for fatigue? Anything related to cancer fatigue? Okay. So I'm gonna have to give you the highlight because I'm gonna skip through all this stuff. Okay, point number one. I'm just gonna make a couple points. And this is really a slide that I give to trainees, like residents and med students, because too often when people hear the word neuropathy, a doctor's like, okay, I'm going to give you Lyrica or gabapentin or Cymbalta, right? But the misunderstanding is that there's actually two parts to the neuropathy. And in neurology, we call this positive symptoms or negative symptoms. So what does that mean? So when somebody has neuropathy, some people have the so-called positive symptoms, which means the burning, the tingling, the electrical feeling, right? They're not positive to you and me, but it's described as positive. And then some people have negative symptoms where, no, my foot's numb, it doesn't hurt. But my balance is off, I can't feel things, I'm falling more often. Some people have both.
Yeah.
Some people just have one or the other. Now, if we don't take the time to differentiate who has positive symptoms, who has negative symptoms, and who has both, we're going to get into trouble. So number one, I have many people who just have negative symptoms. And then yet I see that somebody gave them whatever the drug du jour is, Cymbalta, Lyrica, gabapentin, and there's no point. There's no point in doing that. Why? Because the medicines are just for the positive symptoms, the pain and burning and tingling that hurts. It's not going to do anything for the negative symptoms. Does that make sense? Okay, so if your doctor didn't differentiate that, you differentiate that and advocate for what you might need. And by the way, and this is the reality for neuropathy, this is why it takes time to manage it. It's not like Lyrica or gabapentin or Cymbalta helps everyone. At best, it's 1 in 3 or 1 in 4, at best. So there's a lot of trial and error on finding the right option for each person. So if you do have positive symptoms, and again, this is a laundry list, but when I say anticonvulsants, those are the medicines like gabapentin, Lyrica, certain antidepressants like Cymbalta or Effexor. Sometimes topical medicines can help. I do think acupuncture, massage sometimes can help, but I'm going to focus on, and you could ask me questions, but I want to get on the negative symptoms. So if you have negative symptoms, we need to think about how to prevent falls. Right? If you have negative symptoms, we have to figure out how to strengthen those muscles again and make sure that we enhance your safety. I'm going to come back to that in 1 second. Okay, so these are, ASCO is like the major oncology organization. The only drug they recommend is duloxetine, which is Cymbalta. And even then, they'll admit that it's marginal for many people. They would say that there are mixed studies. I use it. There's a supplement called alpha-lipoic acid. It's used for diabetic neuropathy. I think it might help with chemoneuropathy. Talk to your doctors. Gabapentin and Lyrica, I still think is worth trying for some people if you have pain.
Just for, you use the alpha lipoic acid or you use the R of the R?
I use R. I use
Because the R that is what is actually.
Yeah.
I haven't seen the studies on clinically differentiating that, so I don't know. I'll look into that. These are all for positive, right? Because the medicines aren't going to do anything for negative. Arguably, alpha-lipoic could be tried for negative because you're trying to heal the nerves, but everything otherwise on this list is for positive. The negative is what I want to talk about for a minute. What was another question about positive?
What was CIP?
Oh, that's lingo for chemo-induced peripheral neuropathy. Okay, so there's a basic neurology lesson. Now I'm standing here, right? And if I close my eyes, I'm still going to stand here, right? And I'm not going to fall. We basically have 3 systems for balance. Our vision, telling us where we are in space. The feeling we get from our feet, telling me what I'm feeling on the ground. And like, let's say the balance centers in my brain. Now, I need 2 out of 3 at any given moment to have reasonable balance. So when I have someone stand and I ask them to close their eyes, right, we knocked out 1 system. So that means we're really stressing the feet. So when somebody closes, don't try this alone when you're, right? If someone closes their eyes and they start wavering like this, it's neuropathy, like you do in the shower, right? Because when you're shampooing, you close your eyes and then you're tilting. So this is very important. So what do we do in those situations? Now, there's the safety piece, like a shower chair and shower bars and avoiding walking in the dark. Because remember, when you're walking in a dark room, it's as if you knocked out your visual system. So those are the things you have to remind yourself. But let me give you a thought experiment. If I had two 50-year-old patients, and I told you one of them was a inactive, lifelong, let's say, desk worker, and the other person was a circus acrobat. Now, we gave them the same chemo that caused the same degree of neuropathy. How would each person function? The same? Because they have the same level of neuropathy. Why? The neuropathy is the same.
They develop their balance.
Because they developed their balance, right? The acrobat had more developed balance centers. And that's my point with the slide is Tai Chi and Qigong may or may not improve the neuropathy in your feet. I guarantee you it will improve your balance because you're working on central nervous system, spinal cord systems. So whether it's, again, Tai Chi, Qigong, yoga, PT exercises, that work on single limb stance, tree pose, right? All those things. It's really important if you have the negative symptoms, which many people do, to try to improve your functioning. Well, and it may or may not even help the neuropathy itself. That needs to be sorted out some more.
Doesn't that also help with your osteoporosis because of the weight bearing on one leg, more weight?
So I'm glad you brought up osteoporosis. So when you look at elite swimmers, like Olympic athlete swimmers, and you look at their bones, it's average good. So it really needs to be more. So walking, I think, is fine for maintenance because you're bearing down. But if you have osteoporosis, and again, I'm going to go back to it's weight training. It's walking. We used to be taught that walking is good, and it's weight training. You have to put stress on the bones, and it's really hard to do that without weights. Right. Again, though, you have to be careful with weight training. Okay, I don't recommend anyone start it without some oversight. In our clinic, I think it's kind of hard to find. We've been doing Qutenza patches recently, and it's been rather successful for the positive symptoms. This is especially useful for people that don't want to go on a drug like Cymbalta. It's a high dose capsaicin patch. So capsaicins are available over the counter. Usually it's like 0.01% or 0.01%. And you got to do it 5 times a day, do it every day for weeks. This is just a one-time application. It's hot chili pepper, right? And it depletes this compound that sends the nerve pain signal. And it works for some people. Yes.
So why not just take the natural version of it?
What is that?
The hot, the actual.
You mean to consume it, you mean?
Yeah, black pepper.
It's just applied locally at super therapy, like super food doses.
But if you're taking it internally, and it could definitely reach everything, couldn't it?
I haven't seen any studies. Yeah, I'm gonna wrap it. I haven't seen any studies utilizing it that way. I think it's healthy. I think capsaicins and hot chili peppers are a great health food, but this is for pain. This is used for pain. Yeah.
So it doesn't burn your skin.
Well, what we do is you would come in and we numb up your skin first with lidocaine. Then we're gowned up, we apply the patch, leave it on for about 45 minutes, and then we take it off, wipe it off, and you're out.
And how often do you do that?
No, it's once, and then maybe 3 months later if you wanted a second application.
Maybe
Yeah.
this is just for positive.
Positive only. And in order, you can't put patches all over your body, so it's just if you have focal areas, of neuropathy.
So that would be good for the foot.
You could use it for the feet. Yeah, we've also used it. I don't want to get off topic, but some people after mastectomy have like burning pain, or they have a thoracotomy for lung cancer, and there's like burning pain along the scar. We've applied the patch for those areas as well.
What about the redness effect?
The redness,
The redness effect on his foot. Starts to show, then it can get sore. And other things.
mean from the neuropathy or other
Neuropathy
conditions?
from the.
And you're saying, well, it tends to make the
I
redness
don't know
worse?
about that being applied, but that has been applied about the redness.
Usually when there's severe redness, I start thinking about blood flow issues. So you might want to look for other factors other than just neuropathy with your doc. The other thing, we don't have a device, but UCLA has one. I think City of Hope has one, is something called scrambler therapy. Where, as the name implies, it's trying to scramble the pain messages as it goes from, let's say, the feet to the spinal cord level. Usually these are, this is done over a 2-week period, like every day for 2 weeks. Seems to be helpful about 40–50% of the time. So it's another option just to kind of think about. Okay,
Why does chemotherapy cause neuropathy?
it damages just the nerve fibers. For some, it's not all chemo drugs. Some of them, and not everyone gets it, but certain like cisplatin, oxaliplatin, Velcade.
Will it be tougher after the chemo or it will be there forever?
Well, I usually see recovery for the first 18 months or 24 months. The first year is the most. And then I'm not saying there's no recovery after that, but it kind of slows down, stabilizes. Depending on where you are during the, you know, if you're at month 1, I would say hang tight because there's still a lot of time.
Said if you're in more than multiple people, and you see the most recovery in the first 18 months. My oncologist actually told me that it was what she's seen, and this is Huntington, I know they kind of merged with Cedars Sinai, but she said that she tends to see it get worse. The neuropathy, which of course is a disheartening thing to hear, if you've already begun to get it during chemo, but she.
Well, there's some chemo drugs like oxaliplatin, they call it the coasting phenomenon.
Okay.
So you're going through your cycles and then it ends and then the neuropathy is getting worse, but that's usually the first few weeks
Okay.
afterwards. I mean, when I say months, so there's a possibility, yes, the first month might get worse, but then you bottom out. And
Because of
then
the cumulative effect.
exactly, the train is out of the, you know, is going, and even though you stop the chemo,
Right.
the effect is still going for a few weeks.
Okay.
Yes.
When I walk on an incline, fast walking, or walk upstairs, my neuropathy worsens. But I feel like I need to push myself. So am I doing myself a disservice by pushing myself up hills or on stairs?
So I would say I would base it on your tolerance. For people that I have that struggle with the pain in their feet from, you know, from let's say walking uphill. Sometimes we think about like a stationary bike or swimming because you're not pounding on the feet.
It's kind of cyclical, it doesn't stay permanent.
Yeah, no, it won't stay permanently, but. So you have to use your judgment on how much you want to tolerate, but there are other types of exercise that aren't pounding on your feet as much. You might want to consider. Okay, thank you all.